Let's talk about pediatrics, and we'll start with part 1. And here's what I want to go over with you. I need to make sure that you know about immunizations, but that might be on the list of things you've already decided I'm going to leave. Look, I am not learning those immunizations. If they ask me an immunization question, I'm going to just miss it. Well, listen. If that's what you think, I'm going to help you take it off your list of things that you decided you're just going to miss. Immunizations on your exam are really easy questions, and let me tell you why. You remember I told you that a question takes about a year and a half to make it to an exam? It takes that long to establish reliability and validity. If you were given the task of writing a question on immunizations that was good today, and it had to be good in a year and a half when it finally made it to the exam, would you ever write a question about an immunization schedule? No. Why not? Seems like it changes every year, and questions are very expensive to develop. Consequently, the questions about immunizations on your exam tend to be not about schedules. They tend to be about the immunization themselves. For example, famous event after a kid gets an MMR. About a week later, they get a rash. That doesn't change. Could you give an immunocompromised patient varicella? Never. It's a live vaccine. That's not going to change. So what you should do, and I'll help, is learn about the immune cells, because once you learn that, that doesn't change. That's where questions come on the exam about immunizations. I think you might see one schedule question. I'm going to give you a heads up about it because it hasn't changed in as long as I can ever remember, and I don't anticipate it ever changing. So if immunizations are something you struggle with, use that perspective, use the information I give you, and I think you'll nail your immunization questions on the exam. All right? We're going to talk about that first, and then after we're done, we'll move to a very common behavioral issue that we see in children. That's when it's usually diagnosed. What is that behavioral issue? ADHD. Then we'll talk about some pulmonary diseases. The most common chronic disease in children is asthma. I got to make sure you know about what to do with that. Then we'll talk about the most common cancer that we see in children, that is leukemia. And we're going to end this first section with some neuro disorders. What do you think that's going to be? Seizures, headaches. You got it? We'll take a break in about an hour, and then we'll take care of our last one. All right? So let's get going and let's talk about immunizations. The latest immunization information is always available to you free at cdc.gov. In fact, I can't encourage you enough to use their site, use their 800 number, and use their resources, because I think it's one of your best uses of your tax dollars that you can find. And I'll give you some more examples a little later. But go to cdc.gov. What you will find is that every January, a couple of years ago it was February, but every January, CDC updates its immunization schedule. You should be signed up for one of CDC's free immunization updates. Go to their website. There's a load of information. When there's a change in anything, a vaccine information sheet, they'll send you an email. And that's how you keep up with what the latest is with immunizations. And probably no matter what clinic you work in, you're going to give immunizations to somebody, whether it's a child or an adult, an adolescent, somebody's going to be getting immunizations. So go to the website, sign up for those free emails, and take advantage of your tax dollars. When you're there, I want you to just look at the immunization schedules for perspective. Don't try to memorize them. You can always look that up. This is never something Don't try to memorize them. You can always look that up. This is never something you should put in your brain. So just review them, get some perspective, and honestly, that's all I would do with the schedules. What I think you need to do is realize that about a year ago, or in 2013, I guess longer than a year ago now, CDC changed its immunization schedules. Did you know they did that? We used to have a 0 to 6 year schedule, a 7 to 18 year schedule, a catch-up schedule, and CDC said, oh, Lord, this is so complicated. Why don't we just put them all together in a single schedule? And they did that in 2013. When they looked at what they had done, they said, oh, we think this is more complex than it was before. What can we do to help providers? We can give them footnotes. So they gave footnotes on every single immunization. When I saw the new schedule, I wanted to just die. I hated it. Now, I really like it. I guess because I've had to interact with it. But now, to me, the footnotes seem so valuable. Because when I have a question about an immunization, it seems like my question is the answer is in the footnote. So maybe you'll find that as well. We have one schedule now with a catch-up and an adult, but it's all been combined. And honestly, I think it was an improvement. So here's what you should know. I think you should know about the immunizations, and here's what I think you ought to know. With regard to hepatitis A, what you need to know now is not what it was 10 years ago. Hepatitis A immunization now is universally recommended. What does that mean? Everybody ought to get it. We start giving it at about a year of age. Typically, people get 2 of them, and that's all you need to know about Hep A. Hep B is the one that I think if you see a schedule question, this will be the one. Hepatitis B schedule has not changed in years and years and years, and it is not expected to change. You get the first one when you get it. Most of us did not get it at birth. In fact, I'd be willing to bet nobody in here got it at birth. But hopefully you have it on board now. If you were born today, either at home or in a hospital, you would get that today. About a month or 2 months later, you'd get the second one, and then 6 months after the first one, you'd get the last one. So if you're going to remember a schedule, to me, this is what I would put in my brain. DTaP, what would I know about that? I would just know you need a lot of them. This is the one I would remember because this one is a hot topic right now. It is Tdap. Here's what happened. About 8 years ago, I think about 8 years ago, in the state of Iowa, we had this big pertussis outbreak. And CDC realized that people's pertussis titers had waned over time. So they said, oh goodness, we need to get all these people immunized. So the first people they began to immunize were children. So at 11 to 12 years, they inserted routinely a Tdap. So instead of getting just tetanus or TD at 11 to 12 years of age, a few years ago they said every 11 to 12-year-old needs Tdap. Then they said, you know what? We need to get other people immunized as well because listen, if an older adult gets pertussis, it might kill them. So then it became routine. Every elderly adult who was scheduled to get a tetanus vaccine or booster now gets Tdap. Then they said, wait, we're forgetting about the most important people. What about healthcare providers? They're on the first line. So if you have recently gotten a tetanus booster, you got Tdap is what you got. AP, acellular pertussis. And now, as you heard me talk about last hour, every pregnant woman with every pregnancy gets a Tdap immunization. So now we want everybody to get it. You should get the idea right now. It's a hot topic, and I'm willing to bet you'll see a question on the exam about it. So what about this one? Get it. If somebody needs a tetanus booster, this is what they get. Hib, what would I remember about this? I guess I'd just say they get a lot of them. Move on. What about the pneumococcal vaccine? Do you remember when we first met, I told you how important it was to make sure that your older adults get pneumococcal vaccines? I told you about a new one that protects you against 13 more strains of pneumococcal disease. You need to realize that pneumococcal disease is deadly in a lot of people who get it. So we used to just immunize older patients and people at risk. Several years ago, we realized some of the people who are at highest risk are little infants, which is why now it is critically important to make sure that the PCV13, the pneumococcal conjugate vaccine, is given to infants. I wouldn't memorize a schedule. I would just know that that is a very vulnerable population. They're very, very vulnerable if they get pneumococcal disease. And if you've taken care of peds, you know that we have a lot who die when they become infected with these bad strains. So you got to get them immunized. It saves lives. And you know what else it protects from? Look, otitis media, right? If strep pneumo is a cause, we've seen a drastic decline in cases of bacterial strep pneumo of otitis media because of that immunization. So it's done a really good job. It's been a vaccine success. The next immunization that you need to know about is polio. It's different than the one that you and I got when we were little kids. You got a live vaccine on a sugar cube. Every year in the United States, 6 or 7 children or infants got vaccine-associated polio because it was a live virus. Now, nobody can get polio from the immunization because it's inactivated, it's dead. So just remember that they get several of them, but we don't give oral polio anymore. So question, could you give polio vaccine to an immunocompromised patient? Absolutely. It's completely dead and you can't get polio from the vaccine. A fact that I think you should put in your head is this fact. When you give an immunization that is either live or attenuated means the vaccine is in a coma. It's not dead and it's not alive. It's been hit in the side of the head with a baseball bat and it's just kind of like this. If it wakes up, it could cause disease in some people. So live and attenuated immunization are always talked about in the same conversation. When you give a live or attenuated immunization, we like to hear that the patient had fever. We don't mind hearing that the child had a rash. Because when we see either or both of those, it means that the child or a person's immunization or immune system has responded to the vaccine. So how do you know they responded to a live or attenuated immunization? They run fever or they have a rash. So when a parent calls you the next day and says he has a rash, you always want to know if it's pruritic. If it's not pruritic, you say, oh, that's wonderful. I'm so glad he has a rash. It means his immune system is reacting to the vaccine. That is exactly what we wanted to happen. All right? So put that fact in your brain. Most caregivers are okay with fever because it's so darn common, but they're not usually okay with a rash. And so always ask about the rash. Is it pruritic? Which brings us to MMR, because MMR is what kind of immunization? Live or attenuated? It's an attenuated immunization. So MMR is really 3 things, measles, mumps, and rubella. A good fact to put in your brain is this one. We don't like to give live or attenuated immunizations prior to 1 year of age because infants still have immature immune systems. So when do we give our live and attenuated immunizations like MMR and varicella? When do they get it? About a year of age, all right? So MMR right here is when they get it, about a year. Varicella is the same story. Varicella is a live vaccine, which means we would never want to give that one before a year of age. And again, they get a booster, but what do you remember about MMR and varicella? Don't give them to people who are immunocompromised. Don't give them prior to 1 year of age. Everybody with me? What do you know about the influenza immunization? The flu shot or the flu mist, what you need to know is that CDC wants everybody, if they're at least 6 months of age, to get a flu shot. And even if you've had a reaction to eggs, like hives or anaphylaxis, we have a flu shot for you. We have one made completely without eggs. It is more expensive, but we want you to be protected from flu. Every year in the United States, people die from influenza. And unless you've seen it, you just can't appreciate it. But every year, some community, we had one that happened last year, somebody who was thought to be otherwise healthy, didn't get a flu shot, did get the flu, and did die. And let me tell you, if that happens to be one of your patients, and thankfully that's never happened to me, it will just make you feel sick. So influenza is a big deal. People need to get immunized, and CDC agrees. What about the meningococcal immunization? Here's the important fact I think you should know about that one. The meningococcal immunization should be given to people before they become at risk. When do you become at risk for meningococcal disease? Who gets that anyway? What age? Late high school, early college, which means that we want the immunization on board before they become at risk. You got it? So when is that? Well, when they come in at 11 or 12 years of age to go get their other shots, we're going to pop them with this one, right? Or that's when we'd like to give it to them. There's typically a booster at about age 16, but again, get this immunization on board before the patient becomes at risk. What about HPV? HPV is one of those immunizations that will protect the person who gets it from the most oncogenic forms of human papillomavirus. It's given to both boys and girls. It's in the routine immunization schedule at 11 to 12 years of age. It can be given earlier than that, but generally that's when we get it on board. It takes 3 immunizations, and there's not been a lot of bad PR about it. It seems to be a very safe immunization, and it's one of our newest ones, to be honest with you. It hadn't been out, more than 10 years, I certainly don't think. What about spacing of vaccines? Like, how soon can you give it? A fact for your brain might be this one. CDC wants you to give these vaccines on time, and here's what they're talking about. If you give an immunization 5 days before it should have been given, CDC says, we're going to make you give it again. If you give the immunization 4 days before it should have been given, CDC says, all right, look, we're going to let you slide, but stop giving immunizations early. You need to give them on time. So with regard to spacing of immunizations, giving them too early is associated with this word right here. What is that word? Invalid. Do you know how embarrassing it must be to have to go to a caregiver and say, I gave an immunization too early, we got to give another one to your child? They're not going to have much confidence in you if that happens. So make sure that you know when that immunization is supposed to be given so it can be given on time. Well, let's look at some questions and kind of see where you are with immunizations, and then it'll help you figure out how much you need to study. Look at this question. What is the most important reason to administer Tdap to a pregnant mother in the United States with every pregnancy? Like, how come we doing that? Let me tell you, this really ought to say select all that apply. There are 2 reasons why we give it. We want to protect mother from pertussis, so she doesn't expose her baby if she gets it. But mom has circulating antibodies to pertussis that are given to the infant that last for about 4 months after that infant is born. So why do we want to make sure mom gets Tdap? Because it protects the mother from pertussis and it protects the infant from pertussis. So circle number 2 and circle number 4. Everybody got it? All right, let's keep going. What is CDC's recommendation, for a length of time to monitor a child after receiving an immunization? Okay, listen. Do you remember on the first day that we met, I told you, or I might have told you, that I didn't want you to answer questions on the exam based on what you saw done in clinical practice. I want you to answer every question based on a clinical guideline, a standard of care, evidence-based practice. Let me just show you what I was talking about. When you gave immunizations in your clinic, how many people didn't have the patient wait at all? You just let them leave. Would you raise your hand? Okay. How many people gave an immunization and told the patient you need to wait 15 minutes? Raise your hand. How many people gave an immunization and told the patient you need to wait 20 minutes? Raise your hand. How many people made them wait all afternoon? Okay, good. Did you see the variety in this class? CDC wants you to have a patient wait for 15 minutes after they get an immunization. You know why they want you to do that? Because the most likely time to have a reaction to an immunization, if you're going to have one, is within 15 minutes of that immunization. Now, let me tell you when that really becomes a factor, at least what I think. You will get adolescents who come in for the HPV and meningococcal vaccines. They often drive. If you give them the immunization, they jump in their car and they're driving home 10 minutes later and they have a reaction, that's going to be on you. You need to make darn sure that you have documented that you invited them to wait and they didn't. Because if something happens, That is part of your responsibility, that you have told them it's important for you to wait 15 minutes. So I would encourage you to document it if they choose not to wait. So anyway, 15 minutes and that's the deal. If you get an immunization schedule, it might be this one. What's the recommended schedule for the Hep B immunization? Do you know it? Is it part of your knowledge base? What is it? First of all, how many do they get? 3. When do they get them? 1 month, 2 months, and 6 months after the first one. Circle number 3. What notable event occurs with regularity about 1 week after receiving the MMR immunization? A rash, exactly, number 2. Excuse me. A mother reports that her 1-year-old has an allergy to eggs that produces a non-pruritic rash. All right, is that good or bad? That's good. The question is, which immunizations are contraindicated? And the answer is, none of them are contraindicated. A non-pruritic rash after eggs, you need to make sure that they get their immunizations. All right, so that's a good one. None of them. Look at this question. A mother reports that her 1-year-old has an allergy to eggs that produces hives. Which immunization or immunizations are contraindicated? Well, a common misconception is that you cannot get an MMR if you're egg allergic, but you can. What you cannot get is the traditional flu shot. All right, so influenza. We do have an alternative for people who had hives with eggs who need to get a flu shot. All right, so we have an alternative, but typically the traditional flu shot will be off limits for this patient, but we have alternatives. Look at this one. Which immunizations are live or attenuated? You should be able to figure this one out. I want you to look at number 3. Varicella is live. MMR is attenuated. Live attenuated influenza vaccine, LAIV, is, get it, L, live, all right. But it's cold attenuated. What does that mean? That's a cold attenuated immunization. You know what it means? It can only reproduce in cold places. Humans are not cold. They might be cold-blooded, but they are not cold, right? So you should not be able to get the flu from flu mist, all right? What about the zoster vaccine, varicella? It is what? Alive, which is why we give it never before what age? 12 months of age. So circle number 3, those are your examples of live or attenuated immunizations. A 12-month-old received the MMR immunization a week ago. When can the varicella immunization be given? You need this fact for your brain. Let me give it to you. At 12 months of age, little infants come in to get their varicella and MMR. And they usually get them on the same day. The reason we give them on the same day is because if you give a live and attenuated immunization on the same day, the immune system goes into high gear and produces protective titers for both MMR and varicella. If you give MMR or varicella today and you don't give the one you didn't give, you must wait 4 weeks to give the one you didn't give. If you don't wait 4 weeks, neither immunization will provide a protective titer. So look at the question with that fact in your brain. If the 12-month-old got it a week ago, the question asks, when can you give varicella? What's the answer? In 3 weeks. You got it? So we got to give them at the same time, or you have to wait 4 weeks from the time you gave the first one. Everybody with me? Amelie, that was really tricky. Well, you're going to have some tricky questions on your exam, and I told you I was going to get you ready. Number 3. So listen, I am just thrilled at some of the free resources that CDC has for us to use. And I want to encourage you to call their 800 number if you ever have questions about an immunization. Mom's getting chemo because she has breast cancer. Can I give this child whatever immunization? When he's getting a bone marrow, you call them and you ask them. Let me tell you what they will do. They will give you the right answer. You'll be able to speak to like the world's foremost authority, whatever question you asked. After your telephone conversation with them, they will email you a transcript of what you talked about and what their recommendation was, so you can scan it into your medical record as evidence of why you gave or you didn't give or whatever action you took. I cannot tell you the great use of your tax dollars using CDC is. They've got free apps. They have a thing now that is great. For people who are behind on their immunizations, they will give you, somebody in your office can input what immunizations a child got. And it creates a new updated catch-up schedule for them. You can give it to the caregiver, and then you can scan the other one in your EMR. It's simple work, but if you got to hand calculate who gets what, is it 4 weeks or 8 weeks, it's a mess. So use their free resources. It's just a great use of your tax dollars. Whew. What do you think about immunizations? On your list, or is it off your list? It's on your list. For test purposes. 2014.
They're not going to have the allergy to eggs. They're not going to have the new vaccine that we can give for influenza.
Actually, the new vaccine that you give for influenza was out in 2012. So, but I've never heard a question like that one. And all right, let's launch into these. You ready? Behavioral issues. Here we go. The most common behavioral issue that you probably will run into in a primary care practice, probably in peds as well, is ADHD. ADHD is not a disease. What is it? It's a syndrome. What's a syndrome? It's a collection of symptoms. Well, what symptoms do we see in a patient who's got ADHD? We see 3 of them you need to know. We see hyperactivity, we see impulsivity, and we see inattention. So those are the 3 things that we look at. 2 of these symptoms always run together. That's hyperactivity and impulsivity. And I'll tell you right now, that's a bad combination. It's a very bad combination. These patients are always at increased risk for what? Accidents, injuries. You got it? So we'll look at some examples of hyperactivity and impulsivity. These are children who cannot stop talking in class. These are children who cannot sit still to complete a homework assignment. These are people who have difficulty waiting their turn in line to go and wash their hands before lunch. Those symptoms are characteristic of hyperactivity and impulsivity. Now, when do these things occur? Typically, if a child is going to exhibit these symptoms, they are exhibited by 4 years of age. They peak by 7 or 8 years old. So what grade is that? 2nd, 3rd grade. So as a provider, what does that tell you? When are you going to see them? You're going to see them before the 3rd grade, probably. So typically, these children are brought into your office earlier. The good news about that is that the symptoms of hyperactivity, not impulsivity, the symptoms of hyperactivity begin to decline after age 8. And they decline so much so that by adolescence, typically they are not observable. All right? So that is the usual course of these 2 symptoms associated with ADHD. The 3rd symptom that we see associated with ADHD is one that must be present for diagnosis. The symptom is inattention. And that should make sense to you because what's the name of this problem? Attention deficit disorder. So inattention must be present for this to take place. What are some examples of inattention? This is a child who forgets his book sack at school. This is a child who forgets his homework at school. This is a child who sits next to somebody who drops his pencil, and all of a sudden the child is now enthralled with the pencil that just fell on the floor. So those are examples, common examples of things that we see associated with this. But you know what? You know what gets these children to just trouble? It's their ability, because sometimes it seems impossible. How could you have lost that? Their ability to lose things in their amount of disorganization. That is what creates chaos in their life, and that is what can create dysfunction and chaos in a family where this child lives. The problem with that is that if you're poorly organized and you forget your homework and you never have the right book at home to do the homework that you were given, it creates academic underachievement. So all of these really kind of go together. When do we observe inattention? Typically, if it's not present by 8 or 9 years of age, this is not what is causing the symptoms that you're observing. What else do you need to know about inattention? It is lifelong. So if somebody has this, at 8 years of age, they're going to have it at 28 years of age. You got it? One of the best things that you can do for these people, or these children and these families, is to try to help them create organization. And an easy example is one I talk and have a discussion with every time I meet one of these children. In the morning when they get dressed for school, it is typically chaos in the household. Why? Because the person who's got this can't find both shoes. They can't find their school shirt. They don't know where their books are, and the homework they did last night they can't find. Before they go to sleep, you need to tell them, I got a job for you to do, and I'm going to let you write this down right now. They need to put their school clothes out. They need to make sure when they finish with their homework, they put it in their book sack or their book bag. So try to help them create an environment that will help make them successful. Because honestly, academic underachievement will slow you down for your entire life. So a lot of things you can help them do, or get them referred to somebody who can really provide some help. So how do you diagnose these patients? Well, I want you to look at the diagnostic criteria. We have to find 2 or 3 of those symptoms. The symptoms that we talked about. One of them has got to be inattention, and there's got to be some impact, a negative impact, on the way they function, either academically or socially. If this is who your patient is, this is likely the diagnosis that they've got. The outcome when we treat these children or adults is that things improve for them. What do you mean improve? Their relationships improve. Their academic performance improves. Or they have fewer behavior issues at school. That's what treatment is supposed to be about. Now, in primary care, you need to know where your responsibility stops and who you need to refer. So let me help you see these people. ADHD commonly has comorbids that are associated with it. When a child with ADHD has a comorbid, you need to refer. You got it? What do you mean coexisting or comorbid? I'm talking about coexisting psych disorders like an oppositional defiant disorder or emotional outbursts that accompany ADHD. Those patients need to be treated by someone besides us in primary care. What about people who have tics? I just had a child with this. Came in with ADHD, had been diagnosed by somebody else, was having tics as well. That's not a patient I'm going to take care of. Something else is going on with this patient. And on top of that, he was having loads of sleep issues. In primary care, if the patient has ADHD without comorbids, you should feel comfortable in managing them. If there are comorbids that are also present, it is probably beyond your scope of practice. So how you make the diagnosis? The first thing you do is look for the clues, and we talked about them. But that doesn't constitute a diagnosis of ADHD. What you must do is use one of these standardized scales. And one of the ones that you'll read most about is Conners. Conners has long and short forms. It helps you figure out this and that. It doesn't matter what scale you use, but you need to use one of them. So pick one and use it. What's a drug class of choice to treat this? It's a stimulant, right? What schedule is that? Always a Schedule 2. How do you feel about prescribing Schedule 2s? You know what you need to realize? There is a high potential for abuse. So let me tell you something I observe as I go across the United States teaching this course. You must be very, very diligent and careful when you prescribe Schedule 2 medications because of their high abuse potential. I meet thousands of people a year who take this course, and as I present at conferences, I meet thousands of people. Every year, I meet at least a handful of NPs who are required by their State Board of Nursing to take this review course. They're required to take this course because they have gotten into trouble with writing Schedule 2 medications. Many times it was not something they thought they would get into trouble with, but this is a common occurrence. Listen, somebody comes in for a medication like this, or maybe it's a Schedule 2 narcotic. Every month the patient has to come in and get a refill. The way that they get into trouble is by not reassessing that patient every month. They continue to write the refill. And they do that habitually. If you do that, I will see you again at one of these courses. I would love to see you again at one of these courses, but not because your State Board of Nursing said you need to start again and go get all the basics and then build on it again. So what I would remind you is when you write a prescription for a Schedule II medication, you have got to not only have documentation on your chart about why you gave that medication, but every month that you continue to refill that prescription, you must have documentation on your chart that tells you, yes, this medication is still needed. Yes, his behavior has improved when he's been on this medication. You follow me? I wish I could let you see what I see every year. And you don't want to be the person for whom that happens. And as I told you, sometimes it just happens innocently because you're in a busy practice and you just continue to write the medication. But please, please don't get into that situation. All right, I'm off my soapbox. You ready? Let's talk about airways, and let's talk about children. And just to give you some perspective on airways, I want you to think about this. When you were born, excuse me, your airways may have been this little in diameter. Okay, let's pretend your airways were this little. Now as an adult, let's pretend that your airways are this big in diameter. Well, look, if you get 25% edema in an airway this little, you're going to go into respiratory distress. If you get 25% edema in an airway this big, you're going to have trouble moving air in and out, but you can still do it. So when you take care of infants and young children, I always want you to consider the diameter of their respiratory tubules, because the smaller the tubules are, the more likely they are to get into respiratory distress. So a 6-month-old can turn bad on you very rapidly compared to a 6-year-old. And so anytime you deal with airways in infants and children, I always want you to have the perspective of the diameter of the tubules. So let's talk about asthma. Asthma is the most common chronic disease that we see in children. And you know what? When you can't breathe, it's a very scary event, no matter how old you are. And so, look at my first question for you. In children who have asthma, what are the most important historical clues? Like, what will you pick up as a clue that lets you know about asthma? Select all that apply. Number 1, predictability of symptoms. I think I told you a couple of days ago, I used to work at a pediatric asthma clinic. I told you asthma is not an easy diagnosis to make because everybody who wheezes doesn't have asthma and everybody with asthma doesn't wheeze. My best clue was predictability of symptoms. Every time they get an upper respiratory infection, they have asthma or they have symptoms. Look at number 2, precipitating factors, like a viral upper respiratory infection. Triggers. Every time he goes to the neighbor's house who has a cat, he comes back wheezing or coughing. And finally, family history. So as far as historical clues, these are 4 things that you will ask about and document every time you assess the possibility of a child having asthma. Look at this question. What medications are used to manage symptoms of asthma in a young child? Okay, wait, I'm asking you about what drugs do we give young children who have asthma? Well, listen, I want you to use the same principles in children that you used in adults. The same principles in adults we use in children. We use SABA, short-acting beta agonists. What's an example of that? Albuterol. We use inhaled steroids in infants and children. We sure do. Budesonide is common. Oral steroids. Absolutely. We give runs of those. And very often we use leukotriene blockers, which we really didn't talk too much about in our adults. So what drugs? Actually, all 4 of them. So my clue to you was to use your same principles in children that you learned in adults. There are 2 main differences in treating asthma in adults and in children, and they'll be obvious to you. Here's the first one. The way that we get the drug into a child or infant is going to be different than the way we might get the drug into an adult. What's the difference? We have to nebulize it. In an infant or a young child, we have to put the drug in a nebulizer so that they can get the drug in them. In an adult, we don't necessarily need to do that. We can use an MDI, we can use a discus. We have some way to help them get it in. That's one big difference. The second big difference in managing asthma in adults and in children is one drug. The drug class that drug belongs to is called a leukotriene receptor agonist, a leukotriene blocker. The name of that drug is Singulair. So let me throw this out to you. When we talked about adults with asthma, we really didn't talk about Singulair. You know why not? Because about 1 in 21 adults has leukotriene-driven asthma, which means Singulair is not so valuable in adults with asthma as it is in children, because about 1 in 3 children has leukotriene-driven asthma. That means about 1 in 3 children does very well with a medication like Singulair. Consequently, the big difference in management is how we get the drug in the patient, and secondly, what extra drug we use in children that we don't necessarily use in adults. Everybody with me? All right, let's keep going. So with that, these next few slides ought to be obvious to you. In children, we have a 0 to 4 year asthma schedule. You'll see the drugs. These are the ones we just talked about. And we use the same stepped approach as we did with adults, intermittent asthma, persistent asthma. We have a 5 to 11 year schedule for children with asthma. Same drugs we talked about, or what we've been talking about. We have the same stepped approach to management of it. So really, when you understand the principles of asthma, it will help you, and you'll be able to treat a child or an adult pretty darn successfully. Everybody with me? Take a look at this question. How many episodes of asthma should occur prior to initiating daily inhaled steroids in young children? Okay, now here's the deal. Let me just throw this out to you. For a long time, we have known that the exposure of children to inhaled or even oral steroids will impact their vertical growth. So we've not wanted to expose children to steroids because we didn't want to impact their vertical growth. Consequently, when we choose to give a child daily inhaled steroids, you got to have a darn good reason to do it. What is your tolerance level? The recommendation is number 4. Once you have to give, or they've had 4 episodes in a year, which means about every 3 months, it is time to put them on a controller medication, which means something like an inhaled steroid. Now, let me just throw this out to you. Inhaled exposure to steroids will impact vertical growth, but so will frequent exacerbations of asthma not treated by steroids. You got it? So if you can't breathe, you won't grow. That's the bottom line. You got it? So treat people with asthma. They have to be able to breathe. Everybody good? Let's talk about pneumonia. Pneumonia is obviously an infection of the lung, and the type of pneumonia that you'll be asked to treat in children is called community-acquired pneumonia. And a couple of facts for you. The most common form of pneumonia in young children, meaning 6 months to about 5 years, is viral pneumonia. The most common bacterial pathogen when a young child has pneumonia, bacterial pathogen is the one that we see at age extremes. What's the name of that bug? Strep pneumo, right? So when you treat a child for bacterial pneumonia, the bug you usually are going after is strep pneumo. Now, you remember we talked about the pneumococcal vaccine. Right now, you ought to realize why it's so darn important to give it. Because if we can prevent infection with strep pneumo, we can decrease morbidity and mortality associated with pneumonia in these young children. So how does a child with pneumonia present? Suppose we had an exam table right here in the front of the room and there was a little kid sitting on it who had pneumonia. What would that little kid look like? Well, I am pretty sure that they're going to look sick. I'm also pretty sure they're going to run fever. I'm pretty sure you're going to hear them cough. And they might not be sitting on your exam table. What might they be doing? They might be lying down on the exam table because they have malaise and fatigue. What about the diameter of the tubules in these little kids? Narrow. What about the respiratory rate? Increased. So when we think of older adults, a lot of the symptoms we saw in older adults with tachypnea and increased heart rate are exactly what we see in children who have pneumonia. So how will you manage it? What was the standard of care for diagnosis in an adult? A chest x-ray. That's exactly what we use in children. What would you expect to find in an adult? Infiltrates. That's exactly what we find in children. If the child is dehydrated or very early in the course of the illness, they might have a normal chest x-ray. So remember, treat the patient, don't treat the result. Don't treat the test. All right, you always treat the patient. What about a CBC? You can depend on an elevated white count in these kids. If the white count is greater than 15,000, you need to put money on the table that this is bacterial, and you will treat them accordingly. Now, speaking of treatment, look at my question. What antibiotic choice is first-line treatment for pediatric patients who have bacterial pneumonia? The first question you have to ask is, what bug are you probably treating? What's the name of it? Strep pneumo. If you were treating strep pneumo, what antibiotic would you give? I'm thinking amoxicillin. You don't need the clavulanic acid component. What does that treat? Beta-lactamase-producing organisms. You need high-dose amoxicillin. How much is high dose? 90 mg per kg per day. So what is your best answer? Number 4. All right, so it's not 90 mg per kg twice daily. It's 90 mg per kg per day in divided doses. You got it? So make sure you give the appropriate amount. There are 2 times when we give that very high dose of amoxicillin. One is in the case of pneumonia because these children are presumed to have drug-resistant strep pneumo. And the other instance when we give 90 mg per kg per day is which one? Do you know? Treatment of otitis media, because that bug tends to be DRSP as well. So this is one of those exceptions to how much amoxicillin we give. I'm changing gears. Look at my question now. I want to know the most common cause of bronchiolitis. And we're in bronchiolitis season right now. What is it? RSV, respiratory syncytial virus. What is that? It's a viral infection that affects young children and infants and produces a lot of edema in the airways. So what symptom do you think we see predominantly in these children? Wheezing. Wheezing is always produced by narrowed airways. Look at the first bullet. Do you see what that says? Self-limited. Self-limited. It means it goes away. So the standard of care for many years has been that when a child is diagnosed with bronchiolitis, they're sent home with a nebulizer and albuterol. The standard of care has changed. 18 months ago, the standard of care changed because we had good studies that said, the kids who are diagnosed with bronchiolitis and get albuterol via neb do just as well as the ones who are diagnosed with bronchiolitis and don't go home with albuterol via neb. So the standard of care has changed. We no longer use albuterol unless the patient's got moderate to severe wheezing, but that is the primary symptom that they present with. Very often they have fever and cough, thick nasal secretions. Remember, it's a viral infection and we don't give antibiotics. So supportive care. What is your take on steroids? Do you see them use steroids for bronchiolitis? Yes. What do you know about steroids in the presence of a viral infection? It slows down how quickly they get well. And I guess because of my pediatric asthma background, I am very comfortable using steroids. But you need to know that steroid use, especially for bronchiolitis, is a controversial one. We don't have a lot of good data. But if it's an asthma kid with bronchiolitis, you have to pull out some steroids and manage the edema in the airways. All right. Generally speaking, steroids are controversial and not recommended in kids who have bronchiolitis. Everybody with me? Look at your next patient, a different disease. This is a 3-year-old who has croup, extremely common. What indicates a need for, look at that word, urgent referral? What would make you say in a child with croup, oh, I got to get him out of my clinic? Stridor, exactly. So the Wesley Croup score is what is used to determine whether you keep a child with croup, meaning they don't have stridor, or you get them referred to a place where their respiratory status can be monitored. So best answer, stridor. Get them out of your clinic. Look at this one. Which immunization has nearly eliminated epiglottitis in infants and children? You know what it is? It's the Hib, Haemophilus influenza B. You know who we see epiglottitis in today? Us, adults. Children got their immunizations. Our titers have waned. So I will tell you the last handful of cases of epiglottitis I've seen have not been in children. They have been in young and middle adults. Cystic fibrosis is not just a pulmonary disease. But the manifestations of cystic fibrosis, and sometimes your first clues, are pulmonary, and that's why we're going to put it in this section. It's obviously a multi-system disease. What other system is involved in cystic fibrosis? The GI system, exactly. So you know that it's inherited. It's pretty darn common. And for people who have cystic fibrosis, the big problem is abnormal transport of sodium chloride across cell membranes. So here's my first question for you. How is cystic fibrosis most commonly diagnosed in the United States? Most commonly diagnosed through newborn screening. Now it's part of the standard of care in almost all 50 states that is one of those things that we screen for, just like PKU, just like sickle cell anemia, just like other hemoglobinopathies, but it's through newborn screening. So we have a really early idea that this is what's going on. So listen, what symptoms might be present in a child with suspected cystic fibrosis? What might they have? Let me give you a clue. Children with cystic fibrosis have recurrent pulmonary infections. Who has recurrent upper respiratory infections? Children who have what? Chronic disease. Asthma and allergies, right? So when it's the upper airways, think of allergies and asthma. If it's the lower airways, recurrent pulmonary infection, cystic fibrosis must be in your differential. And so what happens? The mucus can become very, very thick. It's difficult to drain, and that's why they're predisposed to lower respiratory tract infections. In fact, one of the exceptions to using quinolones in children is in a child with cystic fibrosis, because their rates of resistance with so many bugs, they've eaten all the beta-lactams, and so it is not unusual to see children who are infected, who have cystic fibrosis, to receive an IV or an oral quinolone. All right, so FYI. Let's leave the pulmonary section and let's talk about the most common cancer that we see in children, and that happens to be leukemia. About 90% or 9 out of 10 children who are diagnosed with leukemia have some acute form of leukemia, meaning either acute lymphocytic or acute myelogenous leukemia. It doesn't matter whether you are a child or an adult. If you have leukemia, you have the exact same problem. What is it? If you have leukemia, you have failure of the bone marrow. That's what you have. So let me ask you a question. What does your bone marrow do for you? Your bone marrow makes red cells. Your bone marrow makes white cells. And your bone marrow makes platelets. So if you have had failure of your bone marrow, then you are going to have a problem with one or more of those cells. Now, look at the most common presenting signs in a patient who's got leukemia. Most common presenting signs is fever, especially in the evening and nighttime. The most common abnormality that you will find on CBC, which is what you'll order when you suspect it, most common problem is a low platelet count, which is evidenced in those children by bleeding. Now, what kind of bleeding? Frequent and easy bruising. Nosebleeds are very, very common. Now look, before you go borrow trouble with your own children and nosebleeds, who else has loads of nosebleeds? Children with what? Allergic rhinitis, exactly. But nosebleeds are common in children with leukemia. I want you to think about bleeding problems in them. Another common presenting symptom is bone pain. But this is what you have to differentiate with children. When the child is old enough to be an historian for you, you have to ask them when they complain of bone or my legs hurt. You need to ask them, is it your leg, like is it your bone, or does your knee hurt? What you are trying to differentiate is whether it is a joint problem or it is a long bone problem. But generally they will tell you, often they will, their legs hurt. So make sure that you ask good questions. And then finally, At least half of the children who present with leukemia have a solitary or a single big node. They have lymphadenopathy, at least half of them. All right? So these are your most common presenting signs. What about nodes? You should remember your rules about nodes, and here they are. A node is always considered to be enlarged if it is 10 millimeters or bigger. There's some exceptions to that, and one of those is an epitrochlear node. Where's your epitrochlear node? It's right here, right? It's in your elbow. Look, right there. Have you ever palpated that node? It's very unusual. So that node only needs to reach 5 millimeters before that one is considered enlarged. There are two other sets of nodes that get really big. The inguinal nodes get really big, as do the cervical nodes. So when those exceed inguinal more than 15 millimeters and the cervical more than 20, then those are considered enlarged nodes. And so, if you have leukemia, excuse me, you have failure of the bone marrow. That brings about some very predictable findings and symptoms in your patient. If you have issues with platelets because you have leukemia, you will have bruising and bleeding and frequent nosebleeds. If you have issues with white cells, you'll have recurrent infections and fever and swollen lymph nodes. If you have issues with red cells, you will be tired because you will be anemic. And so I think the symptoms should be pretty predictable, or at least anticipatable by, is anticipatable a word? Able to be anticipated by the savvy NP. So what will you do when you examine a patient, a child, an infant, or an adult with suspected leukemia? What are you going to get? You're going to get a CBC. That's going to be your first line test. And while thrombocytopenia is the one that we see most common in children, that is what you look for. So that you don't borrow too much trouble. In children, what is another common cause of thrombocytopenia? Do you know what it is? Infection. Yeah, like post-viral infection. It is not unusual for them to have thrombocytopenia. So while I want you to be worried about these children, not every single one of them with thrombocytopenia is going to be someone who's got leukemia. But it always makes my stomach hurt when the lab calls me with a critical platelet count, especially in a child, because if I ordered that, you know what I was thinking. All right? What's your job after you get these results back? Refer where? PD-HEMONC. PD-HEMONC is going to do a number of tests, and the way that they'll finally get the diagnosis and arrive at how to treat these children is by doing a bone marrow. What do we know about pediatric leukemias? We're using the C word with them. What is the C word? Cure. Cure. All right? So the progress that has been made in childhood leukemia in the last 5 and 10 years is incredible compared to what we knew 15 and 20 years ago. It's just incredible. We now have protocols for adults who are treated with leukemia, the screenings that they need to have. All right? So anyway, let's move on and keep on going. Let's talk about some neuro things. And one common neurologic problem that you will see in children is a febrile seizure. I'll tell you right now that the standard of care in children today who have a febrile seizure is very different than when you were a child if you had one. If you had one when you were a child, you got the big old expensive workup, which included a what? A lumbar puncture. Today, we almost never do that. And so let me show you what you should look for. It is obviously very, very common. Febrile seizures, when we think about risk factors, we think about fever, we think about viral infection. It almost never is a bacterial infection that precipitates a seizure. And I guess what you should remember or think about is this one. Everybody in this room has a potential to have a seizure. Every one of us. If your seizure threshold is exceeded, you're going to have one. So listen. 2 things can make your fever threshold be exceeded easily. One is a rapid rise in body temperature, which is why you should know how to treat fever. You teach your patients to, caregivers to. And the other thing that will make you exceed your seizure threshold is a rapid drop in body temperature. So when you were a little kid, if you had very high fever, your caregiver was instructed to put you in a tub of ice cold water to drop your body temperature. We don't do that anymore. You know why? Because too many people in this room probably had a seizure when we did that. So you were part of a study group. Did you know that? All right. So look at my question for you. Which characteristic must be present for a diagnosis of febrile seizures? I'll tell you right now, it must occur in the setting of an illness. If you're not sick when you have this, it's not the febrile seizure. Sometimes the first clue we have that a child is sick or has some viral infection is because they had a seizure. And the most common diagnosis associated with febrile seizures is otitis media secondary to a viral infection. And so these are the criteria for febrile seizures. It almost never happens in a first or second grader. It is always in a child who is much younger than that, typically greater than 18 months of age. And to be diagnosed with a febrile seizure, you cannot have meningitis. You cannot have any other metabolic abnormality. And so how do we manage them today? Conservative management and making sure that the caregiver knows how to manage elevated body temperature. So take a look at my question. Suppose a child is brought to you from daycare because they suspect that this child had a seizure at daycare. They're now in your clinic and you are looking at this child. The question is, which findings warrant further evaluation? Meaning, you're going to send this child to be evaluated today by either neuro or an ER. Look at your criteria. Bulging fontanelles are never good unless a child is screaming. Look at number 2, ongoing seizures. They're no longer your patient, and that is absolutely never a febrile seizure. Post-ictal drowsiness is a good clue for you. If it lasts longer than 10 minutes, that is not normal. For children who have seizures secondary to elevated body temperature, they have the seizure, it lasts less than a minute or 2 minutes, and then they're sleepy, and then in 2 to 5 minutes, they're like popping up again. If drowsiness lasts beyond 10 minutes, you should be suspicious that it is not a febrile seizure. And then finally, a very ill-appearing child who's had a seizure, you need to make sure they get evaluated by someone besides one of us. Fever management is critical to teach caregivers. Who in here works ER? Raise your hand. How many times have you heard a parent or caregiver bring in a child, you check the temperature, it's 104, and you look at the caregiver and say, when did they last get something for fever? And the caregiver says this, well, it was last night, but I didn't want to give him anything because I wanted to make sure he had fever when you saw him. Right? They always tell you that, like, I'm going to believe you. You've got to manage elevated body temperature. In the United States, we use 2 products because they taste good. We use ibuprofen and we use acetaminophen. That really is why we use them. Listen, AAP, the American Academy of Pediatrics, has 2 recommendations for you. First of all is the one you're going to know and you're going to say, I know we don't do that. Don't, and teach this to caregivers, don't let them put a little acetaminophen and a little ibuprofen in the same spoon and give it. You know why they do that? Because Tylenol drops body temperature faster and ibuprofen drops it longer and better. So if one is good, they put a little of both in a spoon. It seems reasonable to me. The problem is that loads of drug errors. The one that we are involved in is the second thing that AAP says don't do. Don't alternate them. Amelie, don't alternate them. We have patient teaching sheets. We hear our patients about that. I'm sure you do, because everybody does it. AAP says don't do it, and there are 2 good reasons. 1, increased risk of drug errors, because you might be a nurse and remember what you gave 2 hours ago, but the caregiver doesn't always remember. And the other reason you don't want to alternate them is because if the caregiver gives the same drug 2 times in a row instead of the opposite drug, with acetaminophen, we get hepatotoxicity. You know why you don't know about hepatotoxicity in children? Because you're not in the habit of monitoring liver enzymes. Their liver enzymes go way up. The other thing that we see in these children is diminishment in their renal function when they get too many NSAIDs in a row. So the things that we don't routinely look at, we don't know about, but AAP does, and that is the reason for this recommendation about not alternating. So don't combine and don't alternate. My last section for you is on headaches in children. And you probably know that headaches are extremely common in children and adolescents. They have the same kind of headaches that adults have. They almost never have a secondary headache. What does that mean? Secondary to a tumor, a bleed, increased intracranial pressure. Children don't typically have those types of headaches, but they do have migraine headaches with great regularity. Here is the problem. If you had a migraine headache, you might come in and tell me, Amelie, My headache is about an 8 out of 10. It's pounding. It's above my left eye. I'm photophobic. I got to go home. A first grader who has the same exact headache puts his head on his desk and can't find the words to articulate pounding. It's an 8 out of 10. They just can't do that. Consequently, we are not able to get good information about headaches, migraine headaches in children. They have difficulty articulating that. Every first grade teacher knows which child in her room has migraine headaches. How does a first grade teacher know that? That child is always the class vomiter, right? It's the child who vomits. When children put their heads on desks and they vomit, you better do a good job of asking about headaches, because that typically is what they've got. How do you help children with migraine headaches? Look at some of these pretty easy things to do. Elimination, that means no Starbucks cards for these little kids. Do you know how many children have Starbucks cards? Like, I'm amazed. How many children drink coffee every morning before they go to school? They have coffee on the way to school. I'm thinking, I can't believe it. In children who have frequent headaches, especially migraines, caffeine elimination. The same things we do with children about exercise and good sleep hygiene, education, that's what we do in children. We recently got approval of a prophylactic med in children for migraine headaches. It is topiramate. 12 years and older, it recently got this indication, and you'll see plenty of others used off-label. Periactin is one of them. The rules are the same as we use in adults. We want to get them to avoid caffeine and certainly avoid daily analgesic use, like a spoonful of ibuprofen every morning before they go to school so they don't have a headache at school. All right, well, listen, let's finish up with pediatrics. And here's what we'll talk about for about the next 50 or 55 minutes. I need to make sure you know about some of these common GI issues that we see in children. Then we're going to move to some urologic problems, and these happen to be almost all male-related. There's one common urologic problem that we see way more commonly in females. What is that going to be? Urinary tract infections. We'll talk about that. Then we'll look at congenital heart disease, and I got some great news for you. The great news for you with regard to the family exam and congenital heart disease is that what you need to be able to do is not name the murmurs. You don't need to know transposition of great vessels, truncus arteriosus, tetralogy of Fallot. You don't need them. What you need to be able to do is know what clues you would look for in the mother and in the baby that might help you realize or think, you know what, I'm worried about the murmur that I'm hearing. Orthopedics. Several things we'll talk about, but one for sure that you need to know about is hip complaints. All right, so I would expect a hip complaint question on your exam. I have a section here called infectious diseases, but you know what that really is? Those viral exanthems. You know the viral exanthems? If you've spoken to anyone recently who's had one of these exams, both of them will tell you that they have had many, many pediatric rash questions, and I think you'll find that on your exam as well. And then finally, there is one ENT problem that we have not talked about yet, but we got to. What is it? Otitis media. Exactly. So that's where we're headed. Hang with me. I promise you're going to make through the rest. One of the common things that we see in children, pretty common, I guess, is pyloric stenosis. If you don't see this commonly, you must nail it when it walks into your clinic. What happens if you have, or the child has, infant has pyloric stenosis, is they have a stopped up drain. That's what pyloric stenosis really is. So look what happens. We have a stenosed pyloric muscle, and what happens is that as milk or formula comes into the stomach, as long as it can get through the stopped up drain, fluid will continue to flow through. When fluid can't get through the stopped up drain, look, it shoots out the top. And so, take a look. Who gets this? It's way more common in firstborn males than in anybody else, and the time that we see this is generally very early in infancy. So 4 to 6 weeks after birth is when this commonly presents. Now, here is the presentation. We see projectile vomiting. Let me tell you a really quick story. When I was a new NP, I worked in rural health, and I worked with this nurse who I would probably describe, I guess I shouldn't on tape, as an old battle axe. And I enjoyed working with her because she had so much great experience, and she probably kept me from killing somebody. But I mean, she was a battle axe. So I always wanted to know what kind of patient was behind the door before I went in. So one day I'm coming out of an exam room, and she's coming out of the next exam room, and she looks at me and says, "You got a good one in number 2. So I'm looking at her like, what's so good about the patient in 2? Because I knew it wasn't really good. And she looked at me and she just turned on her heel and she just kept on walking. So I knock on the door in room 2. And it was a patient with a new infant that I'd never met before. And so I introduced myself to the caregiver, who was the mother. And I asked her what I ask every patient. What can I help you with today? And she looked at me with a straight face and she said, "My baby has monster vomit." And so for a second, I didn't know if she was a crazy mama, like a Munchausen's mom, or like, what does she have? You know, what's the deal? She said, "Watch what my baby does." So she takes this little bitty infant, she puts him on the exam table, and she pulls a bottle of formula out of her baby bag. She's given him formula, and she keeps pulling it out to check the amount of formula that's still left in the bottle. She puts it in, she pulls it out, she puts it in, she pulled it out, and she said, "Move!" And I jumped because I didn't know what was about to happen. This little baby had vomit that like shot out of its mouth. And I looked because I was just so amazed. I said, "He has monster vomit." Pyloric stenosis is not like a wet burp. Pyloric stenosis is monster vomit. It's this vomit that really is projectile. It was the first time I had ever seen it, and it was like so amazing to me. I've seen it several times since then, and to be honest with you, it is amazing because it's just amazing. That's all I can tell you. Your exam might ask you a question about the olive-shaped mass. Well, listen. Surgeons who do this corrective surgery will tell you, Emily, we rarely feel the olive-shaped mass for 2 reasons. One is they really do have it. It represents hypertrophy of the pyloric muscle. But the best time to find it, if you're going to have it, is right after they vomit. All right? Otherwise, the exam loves olive-shaped masses, but, you know, best time to get it if you're going to find it is right after the baby is vomited. So, your baby has pyloric stenosis. Look, a 4-week-old with suspected pyloric stenosis. What diagnostic test, or what test is most commonly used to diagnose this? What is it? It's an ultrasound, right? Gives good information, no radiation, non-invasive, good information, number 3. Look at this one. What are you going to do? Well, let me tell you what you will do. Obviously, you got to refer. As long as this baby is wetting diapers, it means that fluid is getting through that stenosed area. If they stop wetting diapers, you got to move fast because a little infant will become dehydrated very, very quickly. So right over to ER where somebody can get to them right away is what they need. Everybody good on pyloric stenosis? Reflux is extremely important and common in children. The reason I said important is because the American Academy of Pediatrics just produced a new guideline on what to do with reflux in infants. And one of the messages from the guideline was this one. Primary care providers and pediatricians, y'all are giving way too many H2 blockers and PPIs to little infants who have reflux. Reflux is largely a disease of immaturity of the LES. It doesn't typically mature until about 9 to 12 months of age. So primary care providers and pediatricians, would you please be more patient? When a patient has pathologic reflux, it gets a new name. The new name that it gets is GERD. So how will you manage patients who have this immature LES that results in frequent reflux? Typically, no interventions. Remember that it is important to continue to breastfeed, and sometimes we'll add something that thickens the formula or the breast milk. Sometimes rice cereal is added. And just one more thing. We have a Cochrane review. You know Cochrane, the grandfather of evidence-based practice? I guess that's how you could describe him. We have a Cochrane review that says that sometimes when you change formulas, babies do better. Please know how much one of those cans of formulas cost. Because, I look at some of those cans that cost $60. And I think a couple could go and get 2 really nice steaks at Ruth's Chris for the same amount of money. So it doesn't always result in an improvement of symptoms, especially if it's not pathological. So be very, very cost conscious when you think about changing formulas. So what else? Typically it resolves by about 9 to 12 months of age because why? What happens? The LES matures, exactly. That's the perspective I want you to have with reflux. Here are the red flags, though. This might make you think that something else was going on or that the reflux you were observing is pathological, especially choking with eating, coughing with eating. That makes me think of pathologic reflux or something else. Forceful vomiting might make me think of something else. Anytime there's symptoms in the lower GI tract, you need to be thinking of something besides reflux. So what I would tell you is all of these represent red flags. Fever is never something that accompanies reflux. Everybody good on that? Let's talk about intussusception. Intussusception is obviously a pediatric emergency. And what happens in intussusception is this. Look, the intestine telescopes in on itself. That's what intussusception is. One of the immunizations that I didn't talk about today was the rotavirus vaccine. And I didn't talk about it because I am certain that you will never see a question on your exam in the next 2 or 3 years on rotavirus vaccine, because that immunization has been pulled on and off the market 3 times already, which makes it a very unlikely topic on your exam. One of the reasons that the rotavirus vaccine has been pulled off the market 3 times already has been because of its possible association with intussusception. So we have seen more of it since that immunization has been given. But do we know if that was a real cause? We don't. It is back on the market. So anyway, it is a telescoping in of the intestine on itself. And so here's how the child might present. When children have this and it occurs, one thing that parents observe or caregivers report and report to you is that the child, who could be happy and playing or maybe being held, all of a sudden pulls his knees up to his chest and begins to scream and cry. All right? So that's one of the things that you might observe. We also see something that looks like that in children who have what common benign problem? Colic. Here is how you differentiate it. Colic typically occurs after 1 month of age and is gone by 3 months. This begins at 3 months, so we see this in an older infant. So a younger infant who behaves like that, we might think of colic. In an older infant, this might be what you think of. A KUB might give you some good information, but here is the kicker. You remember when we first met, one of the pieces of advice I always tell a new student that I'm precepting, I always tell them, don't open a butter dish or a Tupperware dish that comes in this clinic. You remember when I told you that? Well, let me tell you what's going to happen. When a child or an infant has this, some unsuspecting caregiver is going to lean over to change the baby's diaper. And when they open the diaper, they're going to go, ah, because there's going to be blood and mucus mixed in with stool. There's more blood and mucus than stool. They're going to look at that and say, oh my God, something is wrong with my baby. They will very carefully fold up the diaper because they want to show it to you. They're so impressed. So they'll fold it up very neatly. They'll put it either in a Ziploc bag or an empty bread bag. Then they put it in their diaper bag and they're coming to see you. When they get into your clinic and they tell you about what the baby's got, they'll say, and you have got to see what was in my baby's diaper this morning. Look, I believe you, Miss Boudreau. Tell me what was in the diaper. What you will find is something called currant jelly stools. If you see that on the exam, this is exactly what they are talking about. It's stools that got loads of blood and mucus in it. More blood, more mucus typically than stool. So that's going to be your big deal. But it's abdominal pain, vomiting, and bloody mucus stools. That has got to be intussusception until proven otherwise. Your job, hunt. All right? So it's one of those urgent GI issues. Encopresis. There's a girl on this slide, but who does this most likely affect? Boys. All right, so what is this? It is involuntary soiling with stool. It's more common in boys, and it's more common after 4, 5, 6, 7 years of age in boys when probably this shouldn't be a problem. The underlying problem in children who have encopresis is constipation. That is what you are going to have to fix. So here's your patient. It's a 7-year-old male who has encopresis. He's had an accident, and the parents have to go to school to bring him clean clothes. When the parents get there, they are mad. And they look at the little boy and they say, why did you have this? And the little 7-year-old will say, I promise I didn't know it was about to happen. Is that little 7-year-old telling the truth or not? He's telling the truth. Let me show you why he's telling the truth. If you are constipated, the intestines are going to be full of stool. The intestines that can't evacuate stool, that stool is going to move into the rectum. And as peristalsis occurs, stool from the rectum is then going to move into the anus. And when peristalsis occurs again, stool is going to come out. So it is a function of peristalsis more than anything else. Stool leaks out, and then the child has an accident. That's what happens in someone who's got encopresis. So look, how are you going to help this child and ultimately this family? Your approach is going to be twofold. The first one is you got to do some client and family education. So here's a little boy. Let me tell you how this happens. Here's a little 7-year-old. He got an iPad mini for Christmas, and he's playing his game on his iPad, and he's having so much fun, and here comes this urge to have a BM. And what does he say? Not now. I'm having so much fun with my game. And he holds it, and the urge goes away. And a little while later, he's playing with his iPad mini, and here comes this urge to have a BM, and what does he say? Not now. I'm having so much fun. And he holds it, and the urge goes away. And he continues to do that, and he's always rewarded because if he holds on to it, he gets to continue to play his game. What you have to do is say, hey, little boy with the new iPad, when you have this urge to have a BM, press pause, go to the bathroom, little boy, right? You have to tell him, answer the call, little buddy. You got to answer the call. So that is the first thing you have to tell him about. Go to the bathroom when you have an urge. The second part of your plan of care is always a laxative. There are very few indications to give children a laxative long term, but this is the diagnosis, and the drug that has that indication is Miralax. Here is your goal. You want this child to have one soft stool every day. almost on command. That is your job. So what you'll have the caregiver do is give an appropriate amount of this Miralax until that occurs. Once they begin to have a stool daily with regularity, a soft stool daily with regularity, then you'll have the caregiver begin to cut back on how much Miralax the child gets and gradually cut back and cut back. But here is the deal. This is not a 2-week problem. This takes a while. And I'll tell you right now that when the child comes in with a caregiver, or maybe both of them if they're an only child, you can feel the tension in the exam room because this makes everybody in the family mad. Just think about it. This is a second grader maybe who's having accidents at school, and every time that happens, somebody has to leave work to go bring clean clothes. As a parent told me, Amelie, this is getting very old. So you're going to have to use some good IPR skills to try to settle things down, let them know it's going to get better, but it's going to take a while because this is what we have to do. So use your good IPR skills and go from there. I'll bet you that one of the most common reasons you're going to see children for GI problems in your clinic, maybe adults, is a viral gastroenteritis. This is extraordinarily common. It's one of the most common infectious diseases that we see in humans. And how is this transmitted? Fecal-oral route, which is why most bathrooms in restaurants have a sign that says what? Employees must wash hands before returning to work. It is to prevent this transmission. So here's your first question. How is oral rehydration for a child with diarrhea usually accomplished? Well, it's not patient preference, even though that might be what it really is in clinical practice. On your exam, if they ask you a question like this, you tell them, why, that would be a commercially prepared electrolyte solution. What commercially prepared electrolyte solution? What would that be? Pedialyte or one of those. So listen, NPs, let me ask you a question. How many people have tasted Pedialyte? Every hand ought to go up. You should have tasted it. Excuse me. If you haven't tasted that yet, on your next trip to the pharmacy or grocery store, you need to buy a little bottle of it. Put it in the back of your refrigerator where it gets really, really cold. And I want you to email me if you can drink 8 ounces of it. It's very bad. It's not something that a child would voluntarily drink. So you may have to use some things to get them to drink that. So commercially prepared is the way you tell them on your exam. Here's your goal. You always want to correct the rehydration. You want to correct the dehydration. So rehydrate them, and then you get them on an age-appropriate diet as quickly as possible, usually after about 4 hours if you can rehydrate them in that period of time. What constitutes dehydration? Well, listen, for mild to moderate dehydration, we typically give about 5 to 10 teaspoons per pound over 4 hours. We would like to rehydrate them pretty quickly. With what? Well, not the things right here. Not a sports drink, although that's commonly used in practice. Certainly never chicken broth. Why not? Way too much sodium. So listen, consider the size of the body that you're putting this into. It's very, very easy to find and precipitate electrolyte abnormalities in little bodies and in old bodies. So be very, very careful with what they get rehydrated with. I made something for you here with symptoms of dehydration, just to kind of familiarize yourself with it. I think these are probably pretty familiar to you. Mild dehydration, we look for sticky mucous membranes. That's one of my saved things in my EMR, right? Sticky mucous membranes. Because when someone sees that, they'll realize this child or person has mild dehydration. Some of these other things obviously are more severe when you see symptoms, but the measures that you should use to evaluate dehydration in actually a child or an adult are these measures right here. Pulse, blood pressure, respirations, the status of the mucous membranes. In infants, the anterior fontanelle. A sunken anterior fontanelle is not something that I ever want to see. You look at the eyes and the turgor and how much urine they're putting out, how thirsty they are, whether they have thirst at all. All of these are things that you will use to evaluate just hydration status in your patients. Let's change gears. You ready? Let's talk about urologic problems where most of these tend to be male-related. A common one is an undescended testicle. So I don't know if you have an appreciation for this or not, but when you started out life, you started out as a single cell and then a clump of cells, and then you got to be a tissue and then some organs formed, and throughout embryology, a lot of movement and invagination had to take place in order for everything in you to get in the right spot. In males, that is particularly important because the testicles are formed and start out in the upper abdomen. Through invagination of tissue, those testicles have got to make it from the abdomen into, look, the scrotum. Now, why are they so determined to get there? Testicles are determined to get into the scrotum because the scrotum is 1 to 2 degrees cooler than body temperature. And that is where they exist optimally. So testicles always want to complete the journey, and the journey's completion means it's gotten into the scrotum. Now, testicles don't always complete their journey. The most common place for them to end up, if they don't end up in the scrotum, is right here in the pre-scrotal area, like they almost finished the journey. Sometimes, and much less commonly, they are in other places. You've palpated them before, I'm sure, in the inguinal area. I don't know how many I've palpated in the abdomen. It's been a few because that's common as well. But here's the deal. When testicles don't end up and complete the journey, you can almost predict in whom that's going to happen. Preemies are way more common than a full-term male. So have that as a heads up. Why are we so worried about an undescended testicle? We are worried because it increases the risk of male cancer. Which one? Testicular cancer. So is that going to be part of your teaching plan for this 10-year-old or adolescent when they get to be that age? It absolutely is. So we worry about undescended testicles because of number 3, testicular cancer. How much risk is increased? Well, it turns out to be a lot. Look at the numbers. Look, testicular cancer risk in the general population is about 1 in 100,000. It's not very common. Testicular cancer in someone who's had undescended testicles, even when it has been repaired, is about 1 in 1,000. You see how much more common it is? Do you see why teaching testicular exam is important in this population? So make sure you do that. As part of completion of talking about this, I got to make sure you know the difference between these terms. Here's the first one. When we use the term cryptarchidism, it means that the testicle never got to the scrotum. It never completed its journey. Another term that we use to describe testicles that are not where they're supposed to be is this term, a retractile testes or testicle. And here's what it means. It means that that testicle at some point was in the scrotum when it was supposed to be. But for some reason, it ascended and it's not in the scrotum anymore. Let me tell you a quick story. I have a patient who has been my patient since he's been about an hour old. This child is very, very intelligent, and when he comes to see me, he is the historian. Since he's been, and I'm not kidding you, about 2 years old, when he comes in to see me, he'll say, "Dr. Amelie, my right ear hurts. It kept me up all night long. My mama's given me ibuprofen and it makes it feel better, but the pain comes right back." He's just like this incredibly cute little boy. So one day, and he's one of my favorite patients, one day, I'll never forget, it's an 11:30 appointment, last one of the morning, I knock on the door and I go in, and it's my little buddy. He's now 4 years old, and he's typically in daycare at this hour of the day. So I go in, I walk in, and there's a pediatric table in the room, and he's playing at the table, and when I come in, he immediately stands up, he puts his hands behind his back and his head down. And I said, "Hey, little buddy, how you doing?" He looked at me and he said, "I'm having a bad day today." So I kind of glanced at his mother and I said, "What's going on today, little buddy?" And this is what he said. "I was at daycare today. I was playing on the playground, and all of a sudden I realized one of my privates is gone." So I turned and I looked at his mother, and she looks at me and she shrugs her shoulders. She said, "That's what he told him at daycare, and I went to go get him." So I look at my little buddy. At this point, I'm down on one knee to get up, to be eye level with him. And I said, "Little buddy, is today the first day you ever noticed this?" And he said, "Oh yeah, today was the first day." I said, "Well, will you let me examine you?" And he said, "Sure." So I examined him, and he was right. He only had one. I told you I have taken care of him since he's been 2 hours old. I know he's had two. So I looked at his mother and I said, "I think I would like pediatric urology to see him. Are y'all willing to do that?" She said, "Oh yeah." So I call my nurse. He comes in the exam room and I tell him, "Call the office, find out when they can see my little 4-year-old patient." He comes right back in and he said, "Amelie, they could see him at 1 o'clock today." So I look at the mother and she said, "Oh yeah, we're going to go." So the nurse gives the mother all the contact information and they're getting ready to leave. And I look at my little buddy and I say, "Listen, would you do me a favor? After you see Dr. So-and-so, would you call me and let me know what she said?" And you should do that too for 2 reasons. One is it's for your own edification. You're going to learn how these things are managed. But the other one, which to me is more important, is you're going to find out how other healthcare providers treat your patients. And you're going to find out really fast who you will continue to send patients to and who you'll never send a patient to again. So I asked him, "Little buddy, will you call me after you see Dr. So-and-so?" He said, "Sure." So they leave. I go about the rest of my afternoon. Honestly, I had forgotten about him. I get a knock when I'm in the exam room, and it's my receptionist. And she says, "Amelie, you got a phone call you need to take." So I'm looking at her. She said, "It's your little buddy." So I go into my office, and I get the telephone call, and I said, "Hey, little buddy, how you doing?" He said, "I have good news and I have bad news." I said, "What's the good news?" And he said, "You were right. She found my private." I said, "Oh, that's good news. What's the bad news?" And I thought he was going to tell me, "She said I have to have surgery, which is how this is repaired." But that's not what he told me. He said, "She found my private, and when we were walking to the elevator to go to our car, it went back up again." Which is exactly what a retractile testicle does, which is why they typically have surgery. So let me tell you, so I saw this little kid just a little while ago. He came in for his flu shot. So I said, "Hey, little buddy, how you doing?" He wanted to tell me something. I said, "What's going on?" And now he's 5. I said, "Hey, little buddy, what's going on?" He reaches in his blue jeans pocket and he pulls out his wallet. And he said, "I want to give you something." So he pulls out this business card. And on his business card, it has his name and it says right underneath it, "Future NP." So he's got his mother's cell phone number on his business card. And he wanted to autograph it for me. So he signs his name on the business card. I said, "Oh, little buddy, I'm going to put this in my office and I can't wait to use this." And he looked at me and said, "I'll probably be taking care of you one day." Which was okay. But let me tell you what happened next. He then looked at me and said, "Would you be all right if I pass these out in the waiting room?" Like, "No, little buddy, these are my patients. I worked hard to get them." Okay, that is the story of retractile testicles. His story is exactly classic of them. All right, so look at your next question. When should a patient with cryptorchidism be referred to urology? When do you say, "You know what, I need to get this patient referred"? The referral time occurs at 6 months of age, and here's why. If those testicles, or both of them, have not descended by 6 months of age, they're not gonna. Within the first 6 months, sometimes they're descended, they go back up, they come back down. But by 6 months, they should both be in the scrotum. If they are not, you need to get them referred. They don't always do a procedure at 6 months. Sometimes they'll give them till a year, see what they can do. But honestly, get them referred early. to protect the viability of the testicles. Another common urologic problem, I think this was way more common, is hydrocele. Obviously, that's a collection of fluid in the scrotum. A common cause, I'll give you in a second. Look at my first question. When does hydrocele usually resolve in male infants? When should your patient's level run out? 1 year of age. If the hydrocele in an infant hasn't resolved by 1 year of age, you need to get them referred to pediatric urology. And so, what might cause persistent hydrocele 1 year later or after a year? Do you know what the most common cause is? It is an inguinal hernia. All right, so make sure that you check for that. A hernia can commonly cause it. And I'll tell you that the most common surgical procedure that we see in children is hernia repair. All right, so again, that's a common cause. The urinary tract problem or urologic problem that we see in girls is a urinary tract infection. And we see UTIs way more often in girls than we do in boys. And there are three usual reasons for these UTIs. The least common is an anatomic abnormality, meaning their plumbing is hooked up incorrectly. Another problem may be something called reflux, where urine is made in the kidneys, it ascends down the ureters, and it collects in the bladder. The bladder spontaneously contracts, and urine goes right back up the ureters. When urine does that, up and down, it very often results in a UTI. So that's a common cause. But another cause, especially in little girls who are older, 3 or 4 years of age, is withholding maneuvers. Like 3-year-old who's at daycare who decides, I don't like the color of the bathroom. I'm not going. And they won't go. So they withhold and they hold urine and they will not urinate until they get back home. So that precipitates, as you can imagine, or increases the risk of a UTI. So these three tend to be the most common reasons we see it. So is it a big deal if a child gets a UTI? It's a huge deal because recurrent UTIs result in renal scarring. If you have this going on at 2 and 3 years of age, you don't stand a chance as an adult. Consequently, we aggressively manage these. If you can collect a specimen, great, collect one. Otherwise, you'll treat them empirically, and typically we use one of two medications. The medication that is preferred is a third-generation cephalosporin because it has good gram-negative coverage, but there's a better reason. It tastes great. The other medication that's been used for years has been Bactrim suspension. If you haven't tasted it, I want you to taste it. If you haven't tasted it, you should make friends with a pharmacist and go smell it. What does Bactrim smell like? Hydrogen sulfide. What is that? Rotten eggs. Exactly. So it's not very good smelling. And when something that doesn't smell good comes close to your mouth, what do you think a child does, and what will you do? You'll lock your lips together. So Bactrim is not the best tasting thing on the block. We almost never use amoxicillin or ampicillin anymore. Very, very poor E. coli coverage. So anyway, have a heads up about pediatric urinary tract infections. If they occur in someone who's less than 2 years of age, you must get a child referred. And on the way to urology, it would be a good idea to get a renal and bladder ultrasound. All right, we typically get that. What's the value of a renal and bladder ultrasound in a patient with a first UTI, especially if they're less than 2 years of age? Why would we do that? Look at number one. It demonstrates the size and shape of the kidneys, and it assures us that they have 2 kidneys. Not everybody does. It can demonstrate dilation of the ureters, which might let us know that something is stopped up somewhere else. It can indicate any gross anatomic abnormality, which means their plumbing is not hooked together correctly, and it doesn't provide radiation. That is why an ultrasound is the preferred imaging study for an infant or a child with a UTI. Always before 2 years of age, but get them referred. Changing gears, look at my question. What disease might manifest itself with a strawberry tongue? Do you remember what a strawberry tongue is? It's where the tongue's papilla become very prominent. They become red and raised. They're very prominent. 2 diseases, what are they? Kawasaki, circle that one. And what's the other common one? Strep, exactly, circle number 4. So let's talk about Kawasaki disease. I'll be honest when I tell you that I have not seen this in at least a couple of years, which makes me feel like I am due. Why is Kawasaki such a bad disease? It's a vasculitis. It's an inflammation of the vessels, and not just any old vessels, but the vessels around the heart, the vessels around the kidneys, the vessels around the liver. Very important things. We don't really know why people get this. It isn't necessarily viral or bacterial. At one point, we thought it was new carpet. Long time ago, we used to think it was that. We don't know why people get Kawasaki, but you got to have an index of suspicion because it needs to be treated aggressively when it is identified. Here are your clues. Typically, children with Kawasaki disease present with high fever for 5 days. But I'll be honest, parents or caregivers often bring them in before that 5th day time frame. So be alert. Here are your big 5 clues. One of them is conjunctivitis, bilaterally, without exudate. So the eyes are red, but instead of looking like regular pink eye, the eyes are red and there's no mucus that's present. The second thing we look for is a macular rash. And sometimes it's papular, sometimes it looks a lot like hives, sometimes it's pruritic, and it is not unusual, and I've seen this before on 2 occasions, where a pediatrician diagnosed this as hives when it was really Kawasaki. And it might be an easy misdiagnosis because it can be pruritic. The third criterion that we look for with Kawasaki is swollen lips or even an oral cavity. So listen, when children run high fever for multiple days and they become on the dehydrated side, it's not unusual for their lips to get dry and swollen and cracked. You see that all the time in children who are not getting enough fluids after fever. So we see that. All of those could be something else. But the one that makes my heart skip a beat is when I look at a child who's got a constellation of these symptoms and I look at the hands and or the feet and they're swollen. Because when you see that, you realize right away, this is not some regular old viral febrile illness. This is something I got to move on and get them to another level of care. And then finally, the 5th one, cervical lymphadenopathy. Lots of kids had that when they run high fever. So those are the clues that you will look for. Look at the picture. Conjunctivitis without exudate. Do you see it? Here's a rash, and you can see how this might be mistaken for hives. You see cracked, dried, swollen lips. What you can't see is the most terrible thing. It's the vasculitis that is going on around the medium and medium vessels around the heart, the kidneys, the liver. So what are you going to do? Well, I'll tell you, I have this in my smartphone because I never want to miss the workup. I don't use this often enough to remember it with regularity. This is the workup. We get a CBC. We get both measures of inflammation in the body in the form of a SED rate and a CRP. Why are we checking an ALT and AST? Liver involvement, exactly. Why are you getting a UA? Proteinuria, blood in the urine. What about a throat culture? We're getting that because sometimes strep masquerades as this, all right, and it'll help rule that out. So this is sort of the workup. When these tests begin to come back and you think this could be Kawasaki, your primary job is to get this child referred. Where are they going? They're going to an ER, right? Unless you got a relationship with a cardiologist, he's going to take them right now. Typically, these children need IV immune globulin. They get aspirin daily, and this is one of the only things that are opportunities that I can remember when we give aspirin to somebody less than 18 years of age. It is in the presence of Kawasaki diagnosis. Why do they get an aspirin? They get it to prevent thrombus formation. Then they get it to help reduce inflammation in the vessels. So it's given every single day. It is weight-based, and sometimes they get it for 2 or 3 months until the immediate risk of thrombus formation has resolved. Everybody good? Let's talk about congenital heart disease, because honestly, what you need to know pales in comparison to what one of the PNPs would need to know. What you have to be able to do is pick up the clues. And here's some of the important clues in the infant. We look for prematurity, because preemies are way more likely to exhibit congenital heart disease than a full-term infant. You remember we talked about murmurs are known by the company they keep? And we said murmurs that keep bad company or bad murmurs. Well, some bad company for a pediatric murmur is something like failure to thrive, falling off your growth chart, being too exhausted and too short of breath to complete your feeding. All of those are poor signs when they are coupled with a murmur that you can hear. What about mom's clues? Look at the first two diseases, diabetes and obesity, or as I call it, diabesity, right? So these are two big clues in mom that increase the risk of congenital heart disease. Do you remember the acronym TARCH? Remember TARCH? It was those infections you never wanted pregnant mom to get. Infection with any of these increases the risk of congenital heart disease in an infant. So if there's ever a question, you get a echo and you always refer. But to be honest with you, I want you to think about the clues that those children get. Abnormal heart rates, loads of murmurs, and again, bad company with a murmur always should make you very, very suspicious. Does anybody want to be at the beach right now? Yep, me too. That sounds like a fun or looks like a fun place to be. Listen, what injury can this produce for the child? What about nursemaid's elbow? You remember that one? Nursemaid's elbow is pretty common. It almost always occurs after a pulling injury. All right, so a pull injury, which means it usually happens in a child who's old enough to walk, at least a year of age. And what happens with nursemaid's elbow is that the annular ligament slips over the radial head. Look, here's a picture. This is the upper arm, the humerus. Here's the lower arm with the radius. Here's your annular ligament, and here's the ulna. If the arm is pulled down or up, whatever direction it's pulled in, this annular ligament has the potential to slip right over the head of the radius. If that happens, and when it happens, in the child in whom it occurs, he is going to put his hand or his arm like this next to his abdomen or his side, and he's not going to move it. Because as long as he keeps his arm right here, he can play with his trucks or do whatever he has to do, and he's fine. No pain. Somebody in the house is going to look and say, "Hey, little boy, why aren't you moving your hand? Come over here." And when they approach him and try to move his arm, that's when he pulls away and he begins to cry because it hurts when you move it. That's when you get him. How many people have had a chance to fix this? Raise your hand. It makes you have a great day. Let me show you how you do it. So here's a caregiver, and you absolutely need her or his cooperation. You're going to get the caregiver to put this child on their lap. Now the child is now becoming very suspicious. You're going to get the caregiver to put his or her legs and immobilize the child's legs. You're going to get him or her to put their arms around the trunk and the unaffected arm. So now what's left is the affected arm. You can get that now. This is when a child begins to scream and cry because he knows trouble is coming. What you will do, and you need to do it quickly and deliberately, is you will take the arm and you apply gentle traction below the elbow. Apply gentle traction. The next thing you will do after you pull, and he's going to be screaming and trying to pull away, supinate, palm up, and then bend. And when you do that, the annular ligament will be replaced. All right, so it'll be back where it was supposed to be. So look, gentle traction below the elbow, palm up, and then bend the elbow all the way up. And when you do that, it'll be back where it's supposed to be. After you do that, look at the caregiver and say, "Let him go." I want you to watch the behavior of that little child because they all behave the same way. They're going to jump off the caregiver's lap and they're going to run toward the door like this. Because all of a sudden they realize, it's like I got my arm back. And after you have done that, they had enough. They're like out of there. So dispense with that visit and go on to the next patient. But again, that's how you do it. And really, it's fun. I always have a good day when I get to fix one of those. It's also not unusual that that recurs. All right, so tell them how it happened. Tell them to avoid those movements. Listen, Osgood Schlatter. What do you know about this? Who is, or which child rather, is most likely to exhibit Osgood Schlatter? Who is it? It's a 15-year-old. This is more common in adolescents. What assessment finding is evident in a patient who exhibits Osgood Schlatter? Do they limp? No. Do they have knee pain? Yes. Worse when they kneel, right? Do they have swelling of the tibial tuberosity? Yes, and you can often pick it up before they even open their word to tell you historically what's going on. Do they have swelling of the patella? They don't have swelling of the patella. So they have knee pain and they have swelling of the tibial tuberosity, circle number 2 and number 3. So what else should you know about Osgood Schlatter? Well, it is more common in adolescents, but you should have an expectation for how long this is going to last. Does this go away in 2 weeks? A month? Not at all. You know why people get this? Because they typically have recently completed a growth spurt and the soft and hard tissue has not grown at equal rates. And until the soft and hard tissue catch up to each other, they will have this problem. So really, a precipitant often is a growth spurt. I usually ask them, have you had to buy pants lately? When they say, oh yeah, he just had a growth spurt, his pants were too short, I know, he's had a growth spurt. So that's one of my questions that I ask. What's your strategy with these adolescents? You want to keep them active in whatever sport they were in, but you want to make sure that you protect that swollen tibial tubercle, because if it gets kicked in soccer or basketball, it's going to hurt a lot. All right? So that's one thing you do. Analgesics is needed, but honestly, keep them active. I am pretty sure that you will see a hip pain question on the exam. When a patient comes in with a complaint of hip pain, you can have a lot of things in your differential, which means that you've got to get a very, very good history. I want to know about how long the pain has occurred. Some of these, even some of the worst ones, have pain that occurs over weeks. I want to know if any of the joint hurts, which might make me think of what problem. J or A, joint, right? Juvenile rheumatoid arthritis. I want to know if they're running fever. Have they had a recent upper respiratory infection? All of those are good clues as to the etiology of the hip pain. Depending on what they tell you will determine what you do next. You may need to get labs, you might need to get x-rays, or you might not need to get either one because you know what it is. Let's talk about these 3 very common forms of hip pain. 2 of them you need to get out of your office. One of the 2 that you need to get out of your office is called leg calf perthes, and this is why you get them out. Look at the first word that describes leg calf perthes. What is it? No, not leg. Osteonecrosis. What would make a bone necrotic? If it didn't get its blood supply, it would become necrotic, and that's exactly what happens in leg calf perthes. Look at the age of children who get this. It happens before puberty. It's way more common in males. So how do they present? These are males who typically come in with a complaint of hip and or knee pain and a limp. All right, so that's their big complaint. When you examine them in the office, you're going to do a Trendelenburg test. Trendelenburg is going to be hard for you to wrap your brain around. And so here's what I want you to do tonight or tomorrow morning when you take off your clothes and you get ready to get in the shower or the bathtub. I want you to put the mirror behind you, and I want you to hold a little mirror. I want you to pick one foot up off the floor, and then I want you to pick the other foot up off the floor, and I want you to watch what happens to your hip height. If you have normal hips, when you pick a foot up off the floor, the hip height is going to remain the same, or it might even elevate on that side. Why? Because you have strong abductor muscles that cause that to occur. If you've got a diseased hip, look, if you've got a diseased hip, in this patient right here, the left hip is diseased. If he picks his right foot up off the floor, then what's going to happen is you will see a dip in the hip. What is supposed to happen is the abductor muscles on the left side are supposed to contract. and keep that hip height at the same level. That doesn't occur with diseased muscles, and that's exactly what happens. You got it? So it's kind of hard to wrap your brain around, but when you see, here's your clue, a dip in the hip, you need to have an index of suspicion for this because that constitutes a positive Trendelenburg. What are you going to do when you see that? You send them to radiology. You x-ray one or both sides? Both sides. You always need the other one for a comparison. And I'll tell you right now, the result of this test is not just going to end up in your inbox. The radiologist is going to call you because this is a big one. This needs an urgent pediatric ortho referral. The second hip complaint that needs a pediatric ortho referral is this one. It's called a SCFE, a slipped capital femoral epiphysis, and I want you to look at what happens. Normally, the femoral head right here fits into the hip joint like a hand in a glove. If you've got a SCFE, look at how it slips. Do you see it? So how do you think you fix that? Look. It gets a big screw that pulls that femoral head back into the hip joint. So listen, how do these children present? They come in with hip and or knee pain and a limp. When you do a Trendelenburg, it's going to be positive, but I want you to look at what distinguishes this from leg calf perthes. Look at the age of the child. It's way more common in adolescents. So this is the one that we see in older children. And again, you'll x-ray both hips and you send them on to pediatric ortho. Everybody good? The hip complaint that you hope walks into your office is this one because it's benign. It's called irritable hip and it is transient synovitis of the hip. Transient means what? It goes away. Synovitis. It's an inflammation of the synovial lining and it causes hip and or knee pain and a limp. What's important to gather in history is that in the last 2 to 4 weeks, these children have had an upper respiratory infection. They've had sore throat, an ear infection, they got a bad cold, one of those, and that's typical. These children will have a negative Trendelenburg. They do not need an x-ray. It's totally self-limited, and in a week or two, it'll be gone. Everybody got it? Let's talk about the viral exanthems. I'll bet you that everybody in this room had almost every one of these. And it's just part of the maturation of your immature immune system as you grow up. We need to talk about these, but don't you have trouble learning and remembering all this? Let me show you how I think it'll be easy to remember it. I made 2 charts for you that I think will put it in a nutshell for you. One of them I want you to pay attention to is the name of the viral exanthem. You should be very familiar with these because you'll see them all the time. And then just look at the etiologic agents, but you don't need to memorize which one causes what. The second chart I think will be very helpful to you, not only in practice but on your exam as well, and here's why. I am pretty sure that you should put a star by measles because I think you'll see that one again. The reason the measles rash often appears on the exam is because it's easy to describe. It's the one that starts on the back of the neck and head and it moves down. So next to this description in your book, I think I would probably put an arrow with it pointing downward, meaning that's the direction that the rash goes. The second one I would put a star by is Fifth's disease, because that's so darn common. The rash with Fifth's disease is very unique. The rash associated with Fifth's disease is the only viral exanthem that produces a macular lacy rash. All right? So it's described as a lacy macular rash. It's the only one that does it. I'll show you a picture in a minute. The other one that I would put a star by is roseola, because I'm pretty sure everybody in here had this. Roseola is one of those diseases where you run very high fever for about 3 days, then the fever abruptly goes away, and what appears? The rash, exactly. So the rash may be on and off for 12 weeks, up to 12 weeks with roseola. When does it appear? After the child gets pulled out of a warm bathtub, after he plays outside and he gets hot. So the instruction that we give always to the caregiver is that this child can return to daycare after he's been fever-free for 24 hours. The rash doesn't have to go away. The only rash that has to go away before they can go back to daycare or school is chicken pox. Everything has to be crusted over, and fever has to have been resolved for at least 24 hours. So I think that will help you with the rash descriptions and questions that you might get. Obviously, children can get all kinds of rashes, and these are some other examples that at least I would be familiar with. But let's look at some more of these rashes because I got to get you ready. Look at this question. What symptoms most typically characterize a patient who has herp angina? You remember herp angina? Man, is a bad one to get, right? So not mild symptoms. Number 2, pharyngitis with tonsillar exudate. Who has pharyngitis with tonsillar exudate? The child who's got what? Strep, exactly. Look at number 3 because this is your answer. It is painful vesicles on the soft palate and mouth. And sometimes it's on the lips or even in the corner of the mouth. Who gets number 4? Rosy red cheeks, high fever, what do we call that? Fifth's disease, exactly. So your best answer is number 3. It's painful vesicles. And look, this is what they look like. My picture is not so great, but you know, it's like little ulcerations kind of, or vesicles. Soft palate, sometimes a hard palate as well. The throat gets very red. Those vesicles hurt, especially when something touches them. What problem do you think this child's going to be very susceptible to? Dehydration, because they will not want to drink. What's your clue? You need to make sure that the caregiver knows to routinely and on a schedule give them something for throat pain and mouth pain so that they can continue to drink and they don't end up in the ER having to get an IV because they're dehydrated. Look at this one. A 4-year-old presents with a lacy macular rash and fever. What might this be? Fifth's disease, exactly. Circle number 3. Fifth's disease is this. I bet you we all had it. Bright red, rosy cheeks, and then this lacy macular rash. It is the only viral exanthem that presents in that way. So let me ask you a question. Do these rashes blanch? Absolutely, right? Every rash blanches except petechiae and purpura, right? Those are the rashes that don't blanch. So as long as this blanches, you know that it's not petechiae or purpura, even though there's very little resemblance with that lacy macular rash to either of those. Look at this question. These viral exanthems don't just pose a risk to the child. A 3-year-old is diagnosed with Fifth's disease. Her mother is pregnant and has had significant exposure to the sick child. She just learned that she is pregnant. If she's not immune to Fifth's disease, what's the risk? Is it a risk? Oh, it's a big one. Miscarriage, right? Intrauterine fetal death is exactly what we're concerned about. So number 1 is your best answer. So how would you measure if she was immune or not? You'd get an IgG, right? If the IgG was positive, say, Mom, don't worry. If the IgM was positive, right? Look at my question. What's the usual age at which roseola is diagnosed? How old do you have? What age are you usually diagnosed? I'll tell you that when you had this, your caregiver picked you up out of a crib. 7 to 13 months, right? Number 1. What about hand, foot, and mouth? It is pretty darn common, and the symptoms that these children present with are fever and oral vesicles. I'll be honest, these children are never as sick as a child who's got herp angina, though they have some similar symptoms. One thing that makes hand, foot, and mouth interesting when you see it the first few times is that the soles and the feet have these little vesicles that become papules and macula and then they go away. And it's on the hands too. And it's really just kind of unusual that you see that. So vesicles, and you'll see them just kind of papules, and then they go away. It takes about 3 days from the time you see a vesicle for it to go away. And you'll see things in the mouth as well. These children generally do not run fever as high as a herp angina child, and these children typically are not nearly as sick. All right. Measles is characterized by what clinical findings? And I'll tell you, we're having measles outbreaks across the United States. We just had a big one in Texas. What is it? What are the clinical findings? The 3 C's, what are they? Cough, coryza, conjunctivitis, circle number 1, 2, and 3. Those 3 things characterize measles, as does Koplik spots. Put a star by Koplik spots in case you see it again. Those are those little spots on the mucosa, and when we find them, it's almost pathognomonic for measles. Look, we see a rash on the skin that looks like this, and then Koplik spots look kind of like little grainy things stuck on the mucous membranes inside the mouth. When you see that with the rash and the conjunctivitis, cough, and coryza, that's measles until proven otherwise. And so we've arrived at the point where we're about to talk about our very last thing. Thank God, Amelie, I'm so exhausted. Listen, let's talk about otitis media. You need to know the difference between acute otitis media, which means there's fluid and systemic symptoms, and you need to know the difference between that and otitis media with effusion. Effusion means they don't have systemic signs, but there is fluid behind the tympanic membrane. You probably know that we got new otitis media guidelines from the American Academy of Pediatrics in early 2013. Fair game on your exam, and certainly you should be following these in your clinical practice. The whole point of these new guidelines is to tell you what to do when you diagnose otitis media. Should you give an antibiotic, or should you observe the patient and be patient? So take a look. When we look at what causes otitis media, the most common cause is a virus, which is why we're reluctant to give antibiotics. When it is bacterial, the 2 most common pathogens are strep pneumo and H. flu, Haemophilus influenza. So when we find and identify and diagnose a patient who's got otitis media, age is a driver of our action. If they're less than 6 months of age, we don't want to guess wrong, and they haven't been fully immunized against strep pneumo, so we are more likely in someone who's less than 6 months of age to give antibiotics, whether we know they've got it or we just think this might be it. If they are between the ages of 6 months and 2 years, they haven't necessarily been fully immunized against strep pneumo. If we know that they've got otitis media, we treat with antibiotics. If not, and it's not severe, we will observe, and you're more likely to observe the older and closer to 2 years old they get. If they are an older child, greater than 2 years of age, they pretty much have been immunized against most forms of strep pneumo. If you guess wrong, they're more likely to be able to do okay afterwards, and so we withhold antibiotics unless the illness is severe. The bottom line is this is how we manage it. Here is your patient. A 2-year-old is diagnosed with otitis media and an antibiotic is prescribed. When should her fever resolve after starting the antibiotic? 48 to 72 hours. If it resolves in 36 hours, good for you, but really you should expect 2 to 3 days, we ought to be seeing a significant improvement. A healthy 2-year-old is diagnosed with otitis media. If you're going to prescribe an antibiotic, how much amoxicillin should be prescribed for her? Remember the exception to the rule about how much amox we give? For DRSP in the lungs, we give 90 mg per kg per day. The other exception is this one, otitis media. We prescribe 90 mg per kg per day. So what's your best answer? Number 4, exactly. So not twice daily, once daily. So let's talk about the antibiotics quickly. Unless a child has had recent antibiotic exposure, we assume that it is strep pneumo. You have 90 mg per kg per day, and amox ought to get it. If they have had recent antibiotic exposure and they're sick again, you should assume a beta-lactamase producer, and the guidelines suggest a drug like an Augmentin, amoxicillin with clavulanic acid. Please don't forget to give these children something for ear pain, because you know it's got to hurt, right? I mean, they cry when they come in with ear infections, and I think it's because it hurts.